Alright, ladies and gentlemen. Gentle. Why are ladies called ladies and men are called gentlemen?
Because ladies are inherently gentle. Men are not.
Why are we called very gentle?
No, I'm just saying, why are ladies called just ladies and guys are called gentlemen?
Because ladies are inherently gentle. So
Ladies?
But guys aren't gentle, so why are they called gentlemen?
Yeah.
Because you want to specify
I mean,
the
that's in there.
gentle.
But they have to be gentle. Huh? No.
Men need a constant reminder.
A what?
Men need a constant reminder.
That they should be gentle? That's true, that's what I'm saying, they're not gentle. Why should...
You specify only the gentlemen are welcome. But all ladies are gentle. So my fire department, like government fire department job,
Yeah.
in New York.
Yeah.
I applied for it in August. I just got my listing yesterday.
That's nice.
My listing, which is actually like 900 something. It's probably gonna be like a couple of months more
Yeah.
before I even get a chance at applying again.
Can you transfer it here?
I have to take the national exam.
What did you apply for?
Because we have a fire...
The EMT department, fire department.
Because we have the fire department right next door.
Yeah, I just gotta take my national exam and then keep my application. Okay, guys.
I was trying to think, what are certain things that Chicago people only say? Because you know how there's like things, right? That's the only one I could think of, but what else?
A what?
Like, what are things that only Chicago people say?
They don't say cool, they say something else.
Chicago. Yes, sir. Yeah.
Isn't this hepatic duct?
Ask my brother, does he put?
What is it?
Hepatic duct.
What about it?
It should end with the gallbladder.
Yeah. It's correct.
It's with the bile duct.
Okay.
Common bile duct.
So, let me label it for you.
Is the cystic duct,
A, B,
right, and
C,
hepatic ducts,
D,
common hepatic duct,
E.
bile duct.
Which one you have question with?
B.
Yeah, B is right hepatic duct.
Yeah.
And C is left hepatic duct.
It shouldn't end open within the gallbladder.
No, it varies. Not within the gallbladder, no. Usually, I mean, it will be... It varies on, but majority of them there's hepatic duct, and the hepatic duct will split into two.
I have a question about that.
Yeah.
How does the bile go against the flow into the gallbladder?
Oh, this is the diagram is messed up.
No, because this is an anatomical issue.
You see, the issue here is when you don't have food, when you don't have fatty food, when you don't have, for example, CCK, bile will only come. Only CCK can push it out. You need gallbladder contraction for bile to actually come to the common bile duct.
Normal flow is towards the gallbladder.
Yeah.
Unless you see it present in the gallbladder.
And the sphincter already is closed, so it piles up all the way up to here, and it automatically goes there. Yeah.
Patients who have gallbladder surgery removed, how does that affect them as far as the bowel?
Okay. The question is that patients who don't have gallbladder, who have gone through cholecystectomy, what are their bowel habits and movement and so forth? Correct.
If they don't have bile to break down.
Yeah. So if they don't have gallbladder, that means they cannot store bile in the gallbladder, but it's stored where? In the bile duct, hepatic duct, and everywhere else. So if they eat fatty food, they will still release some bile, but not enough, you know, depending how much fatty food they eat. So in the first few weeks of post-surgical removal of the gallbladder, they might have some discomfort, some, you know, not necessarily pain, some discomfort, and maybe some diarrhea because of lack of digestion of fatty food. But then they will adjust. Then the body will adjust.
So they won't have any issue with malabsorption.
Would they have any issue with malabsorption? No. Well, I mean, as I said, in the first 3 weeks, it would be mild, but not really, no. Yeah, they'd be normal. They'll be intolerant up to an extent of fatty food. They'll not be able to tolerate the way they used to. They'll get adjusted, yeah. Yeah. Capiche?
I have a question.
You do too?
Mm-hmm.
Awesome.
So if a patient with chronic pancreatitis, would they also have yellow-blastic anemia? Because pancreas is the one that releases bicarbonate in the duodenum, and that's where intrinsic factor gets activated. So if it doesn't release, doesn't get activated, so how can you absorb it and determine ileum?
What she's saying is intrinsic factor activation requires? Intrinsic factor activation requires? Bicarbonate. Now, people who have chronic pancreatitis, they don't have any bicarbonate release. They do less. Yeah, not zero. You know, if you have zero bicarbonate, intrinsic factor is the least of your problems. You will have more acidic problems, ulcers. Okay? And beside that, we have Brenner's gland, and the entire intestine has what? Goblet cells. They produce bicarbonate regardless. So it's not necessarily that pancreatic bicarbonate is solely essential. It helps, it aids, it makes it easier. Yeah. So, and beside that, food is usually in that area is enough basic. Any basic solution would activate intrinsic factor. Acidic will inactivate it. That's the difference. Okay? Yeah. They could, in theory, practically, extremely rare. Yeah. Anything else? No. No questions? Only two people are asking questions? One from the front, one from the end? Okay. You're the front. Alright. So let's go over the... I'm getting lazier and lazier. Let's just finish this because... Thank you, Asra. Yeah.
Actually, we discussed super antigen.
Huh?
We discussed super antigen. When you were asking.
Super antigen. Please tell us.
So, from my understanding, is when macrophages digest a bacterial cell, they release some of the fragments onto the outside of the cell using the MHC complex.
Mm-hmm.
And antigens, this is the way that T helper cells recognize it, but with super antigens, they conform the MHC complex. So when T helper cells come to bind to it,
Good job.
they trick them, and it's causing overproduction of T helper cells, which exaggerate the inflammatory process.
Trick them. Yeah, you could say that.
Well,
Sure.
by, like, making symptoms that
Yeah. That's correct. But let me show you something.
Not to produce these cells.
Isn't that they're just very
Produce T cells.
non-specific antigens, so they just activate many T cells, and the T cells produce interferon gamma.
How could one super antigen activate many T cells? That's the question.
It's
How?
Well, essentially, it's an enzyme, technically.
Uh-huh.
So what it does is it doesn't have like a fixed structure, and it conforms to all the T cell receptors.
So that means when it activates one T cell, then it's kicked off and it goes to another one, and then another one, another one. But that will take forever.
No, there is a lot of super
Yeah,
antigen, a lot of particles.
And it can bind many on the same side.
Okay, let me show you something. It's correct. See, when you read stuff, sometimes you have to imagine things. Okay, sometimes you have to imagine and apply. There's more to it than what you guys are amazing, correct? But there is a process you need to understand first. Okay, I don't want to erase
And then they get
this.
surrounded by like antibodies and just activate like from all sides, so one can activate like many cells at once.
Yeah. How do I do this? Smaller? Okay. Okay, so let's use this side. Now, number one, you have macrophages. Now we're gonna think of similar idea to police and thieves and whatever, or aliens, you know. Okay. So they're a group of cells known as antigen presenting cells. So this is antigen presenting cells. See, the job of antigen presenting cell is first to recognize an antigen and then inform the main center in the city. Hey guys, you know there's a lot of problems, there's a lot of thieves, there's a lot of aliens. Can you so the main center in the city, let's say that is the antigen presenting cells, and then it will go called the main center. The main center is actually the recruiting center. It will recruit all police from Chicago, from Palos Hills, what else? Schaumburg, and then what else is there? Naperville, Lombard, blah 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 blah. All of them to come to the site of what? Injury or inflammation or whatever, there's something wrong happened or accident or whatever. Okay, so that's the idea. Now, in order for antigen presenting cells to inform the main cells of the immune systems are known as T helper cells. I'll put TH. TH actually does not involve in attack or getting their hands dirty. They simply recruit and recruit and recruit. They're the manager, they're the bosses, they make the phone calls. Okay, they don't get involved in antigen processing or antigen killing or anything like that, not at all. But there's the thing, you know, antigen presenting cells are actually very smart. They will not transfer the information unless they themselves know for sure it's the right information. For example, when we hear something, do you ever confirm if it's true or not? General human being, when they hear something, they're too excited, they just tell people, even though if it's true or not, they don't care. And that will cause a lot of problems because you give other people a headache. You mislabel people, you do this. I'm talking about all the negative gossip stuff. Antigen presenting cells are not like that. They have to process the antigen themselves. They have to check it up if it's truly antigen, if it's truly toxic or not. Otherwise, they won't do it. Okay, so first of all, they have to recognize the antigen. Now, macrophages on the surface, so they do this by the process of endocytosis. B cells do the same thing. Once they take this antigen, and if this antigen is foreign particle, then it's, let's say this is a huge antigen, big one, like here. So this is phagosome. It will combine with lysosomes. Lysosome will release its enzyme. Okay, I'm giving you more than enough details, but as long as you get the overall idea. And then when the lysosomes release its enzyme, this antigen is cleaved, processed, broken down to tiny little pieces. The piece that's causing the problem, the piece that you can recognize as an antigen, or for identification purposes like your passport, your driver license, only that piece is expressed on the surface with MHC2. Let's say the red particle with MHC2. So first it has to take the antigen, and it has to be, you know, macrophages have to be themselves satisfied that this is actually a foreign or toxic particles. Otherwise they won't do it. They're not immature. They will not do the wrong thing. So once they present it on the surface, only then the T cell will say, oh my god, look at this. My informer just told me there's something foreign, there's something problematic. Let me take care of it. Okay. So then T helper cell will have on their surface TCR. This interaction has to occur. Now there's the rules. TCR, this, you see this, the thing looks like T on T helper cell. This is TCR, or T cell receptor. TCR stands for T cell receptor. T cell receptor, TCR. So TCR will not recognize an empty MHC2. Just because macrophages express MHC2 on the surface, they're bluffing, they won't recognize it. Again, they're smart too. They don't just take anybody's word. They check to make sure that it has a substance, it's true. So the information that's passed on is checked on multiple levels to make sure it's correct information. T cell will not accept wrong information, will not accept just bluffs and gossips and stuff. And macrophages will not present something that's not true. So there's a lot of checks and balances. So now TCR, when they check, you know, okay, MHC is not empty. It is in association with a foreign antigen or toxic antigen. Let me recognize this. And then it will attach. When this attaches, then macrophages will release something, and eventually T cells will get activated. T cells will release two things. This will be T helper 1. Interferon, gamma, and interleukin 2. Okay, interferon. Okay, or IF. Let me use IF, is more accurate. So produce interferon gamma and interleukin 1, interleukin 2. Interleukin 1 is produced by macrophages. Let's just ignore that for now. Okay. Now macrophages, once this association occurs, macrophages release interleukin 1 and 12, which activates T helper cells to produce these two. First they have to attach. They have to shake their hands. You know, I agree. Whatever you're presenting to me is toxic to me. I'm going to take care of it. Macrophages says, sure, let me release interleukin 1. So macrophages will activate T helper cell 1. Before that, they were immature T helper cells. They're known as T0, TH0. TH0 can become 1 or 2. Let's not get into much details, but anyhow. Now, you see this interleukin 2? How many cells have so far been informed of this antigen? Only 2. Macrophages and T helper cell 1. IL-2 is a T cell growth factor. T cell growth factor. IL-2 is a T cell growth factor. So this IL-2 will cause increased production of what? More TH1. So instead of having 1, now you have 20 TH1. A lot more. You see the information amplified from 1 to being 20 T helper cells. I'm exaggerating. I think it's more. Okay, so a lot more. Now, interferon gamma acts on macrophages and it produces its macrophages growth factor. Macrophage differentiation factor. So now you have, instead of 1 macrophage, how many macrophages? 1,000. 1,000 T helper cells, 1,000 macrophages. And each one of them now responds to the specific antigen. Only one super antigen can do this. I haven't even gone super antigen. Okay, so this is processing of the same antigen. And then you see, instead of having one police dealing with one thing, you have thousands of police, thousands of call centers. And your signal get amplified. And then the whole city knows about this issue. And then it's almost like CNN. How about that? Boom. The signal is amplified and they make judgment. And let's take care of this. Okay, and then all these will come in onto that side of inflammation. We'll take care of it. Now, this is normal. This is normal. This takes time. Antigen processing takes time. Right? All this entire process takes time. Super antigen. Now, to understand super antigen, I'm going to go, let's get rid of these things. You understand that part. You see TCR, let me use green. TCR, this is TCR. TCR. TCR can only recognize proteins, number 1. Proteins and peptide. TCR has limitation. It cannot recognize sugars, DNAs, and lipids. TCR has limits. It can only recognize what? Peptides and proteins. Therefore, the strongest antigens are what? Proteins. And your whole body is made of protein. It makes sense. That's one. Rule number 1. TCR cannot recognize anything but protein and peptides. Good? Now, TCR cannot recognize protein that is freely floating around. The only protein it can recognize if it is in association with what? MHC2. And these two blue lines right here, this is MHC2. So TCR cannot recognize free antigens. They can only recognize peptides and protein if they're presented by who? MHC2. So both criteria must meet. If you have a free MHC2, would TCR recognize it? No, it's normal, it ignores it. If it's free antigen floating around, no. So again, TCR has limits. Okay, and TCR is important for what? Amplification of a signal. Without it, you can't do anything. It's like a dispatch. Okay, so now super antigen. In addition to that, there's something known as CD4. Okay, which will will strengthen this association. It's like a hook to make sure these two cells don't dissociate. They stay together. As long as they're together, they can produce more and more product. Okay. Now, super antigen. Super antigen does not need MHC. Where is it? How can I do this? It does not need MHC antigen association. Super antigen is a larger antigen. Guess what it can do? It attaches to both of them at the same time. There's no processing needed. There's no processing needed. Antigen is not processed. This is the uniqueness about super antigen. It's not processed. It directly attaches to what? MHC2 and TCR at the same time. It avoids being processed. And this will produce tremendous amount of T cells and macrophages and whatever else needed. So it's not that each super antigen goes from one cell to another. No, once it's used, it's used. Okay, one super antigen attaches to this one interaction, it's consumed. The other ones will attach somewhere else, you know. So that's how it works. It avoids being processed by antigen presenting cells or macrophages. So super antigen can cause tremendous inflammatory response. Tremendous. Now super antigen usually can cause shock, food poisoning, right? Yeah. Okay. So I hope you understand the logic behind super antigen. Any questions? What you read in something that you want me to go further? You're good? Okay. Now I hope we understand when it comes to gallbladder. Gallbladder simply stores bile. A is cystic duct. You need to know the name. B, right hepatic duct. C, left hepatic duct. D, common hepatic duct. E, bile duct in general, or common bile duct. Yeah. Okay. And an unlabeled duct. P. Okay. D. Duodenum. G. N. Neck of the gallbladder. Good job. All right. Okay. Now we need to understand this. So now gallbladder, remember that it should be looped around duodenum like that. I just do it for simplicity so you can understand it. Okay, it should be. That means gallbladder, the body is attached to what? Duodenum, first part of duodenum. In the tip, the fundus, colon, transverse colon. Okay.
Wouldn't the head of the pancreas also be there?
Yeah, the head of the pancreas is there too, but it's not going deeper into it. Okay. Alright, so that's important when we talk about these things. At the end of the day, gallbladder does only one thing. Store and release bile. Store and release bile. Nothing else. Store and release bile. And you know that hormones that act on gallbladder are what? CCK and secretin. Good enough? Alright, so I can erase it now, right? Okay. Now, disease of gallbladder. Whenever you hear the term bladder, it means what? Storage. Bladders generally store things. Urinary bladder stores urine. Gallbladder stores gallstones. I mean, that's misnomer. It should be cystic bladder or coli bladder, cholesterol bladder, or bile bladder. But anyways, I guess they discovered it first because of gallstones. So let's talk about gallstones since the name came up. Maybe gall means bile. I have no idea. So gallstones. That's one disease of gallbladder. Can you think of any other disease of gallbladder? Yeah. Inflammation of gallbladder. Cholecystitis. Cholangitis. Let's discuss these three. Okay. Now remember that in life, no matter what the diseases are, you can categorize them into few categories. Inflammation, infection, tumors, ischemia. Right? Most of the time, these are the diseases. And then you can include in this genetic component too. So all diseases have few of these causes. Gallstones. Okay. Let's talk about the gallstones. What are they? Huh? It's made of cholesterol. So there's type of gallstones known as cholesterol stones. Very good. Cholesterol stones. Type of stones. Cholesterol stones. That's one. Pure cholesterol stones. Anything else? Bilirubin. I don't know who gives them this name. Billy and Ruben. Huh. Anything else? Phosphate. Phosphate what?
Cholesterol phosphate.
Huh?
Cholesterol phosphate.
Yeah, so cholesterol stones, pure cholesterol stones, cholesterol phosphate, bilirubin phosphate, same thing. Okay, so phosphate will just accumulate, and then you have the combination of these two. What is that? Cholesterol, bilirubin combination. Yeah, stone. 3 stones. I'm not joking. Okay, so majority now, 90% of all gallstones are what? Cholesterol containing. Cholesterol stones. Okay, pure cholesterol stones, maybe they will have some electrolyte attached to it. Maybe phosphate, maybe sodium. Okay,
So 90% of cholesterol.
cholesterol stones. Not purely cholesterol, but just overall cholesterol. Meaning, look, 90% are what? These two. Amongst these two, cholesterol, pure cholesterol is more common. Okay, bilirubin is rare, like 10% or something. Okay, now let's talk about cholesterol stones first. What are the risk factors for cholesterol stones?
High cholesterol diet.
So, is it okay if I remove the mixed one? Because you already know. Cholesterol stones. What's the risk factor for cholesterol stone?
Hypercholesterolemia.
Okay, plasma cholesterolemia. Very good. So type 2 hyperlipidemia. Type 2 hyperlipidemia. Cholesterolemia. Cholesterolemia. Anything else? For cholesterol stone, usually there are mnemonics. Mnemonic again, when it comes to F, I don't know use the second part.
Female fertile.
Obese instead of F, and 40s. Okay, so female are at risk, and that's all because of estrogen. Fertility for female is due to what? Too much estrogen. You know, obesity increase estrogen, so it's estrogen that puts you at risk. Okay, so female. Now estrogen does, guess what? Estrogen, you know that aren't female at risk of, who's more at risk of, female or men before menopause at risk of cardiovascular diseases? Why is that? How? Combine it to this, to what we're saying now. See, we're saying now female are at risk of cholesterol.
Being protected. Should that, I forget.
Isn't estrogen coagulative?
Mm-hmm. Yeah, it increases thrombotic events, but yet it decreases what? The risk of? Not thrombosis. Atherosclerosis. Estrogen is protective against atherosclerosis. Atherosclerosis.
Testosterone causes
No, not in that sense. Yeah, estrogen is protective. Why?
It's basically
Cholesterol deposition.
Look, if I'm telling you, just listen to me, maybe you'll figure it out, guys. If I'm telling you, estrogen protects against atherosclerosis, but increase the risk of gallstones.
Oh,
oh,
Just calm down. Isna. That'll produce more cholesterol.
So it keeps the
cholesterol is getting stored in
inside,
the
keeps
body.
it stored.
Huh?
Keeps the cholesterol stored.
How so?
As gold.
There's one simple thing. A simple thing. Just relax. Sometimes you guys are too
Say one more time.
patient.
It will
Less
increase
patient.
production of bile salts.
He's got it.
Yeah,
Cholesterol is made into estrogen.
that's true. But again, that's if estrogen increase, that will decrease cholesterol, less gallstones. Just look at the concept.
Cholesterol is getting stored in the gallbladder instead of being stored in like other tissues, form atherosclerosis. Alright.
Atherosclerosis occurs where?
In the blood vessel.
In blood vessels. Gallstones occur where?
Don't
That means cholesterol is transported to where? Liver. Estrogen increases uptake of cholesterol by liver. That's all. It increases LDL receptor on the liver. So So that means you decrease plasma cholesterol and increase bile cholesterol. Bile cholesterol, not necessarily gallbladder, bile cholesterol. And then if the female is less active, and then the bile is more stored for long term, it will become stones. Now, precipitation of stones is what? Stasis, number one. Stasis. Decrease gallbladder contraction. Decrease gallbladder motility. Okay? And decrease bile saturation, meaning that if there's less fluid, more bile, bile is primarily saturated with cholesterol. Okay, so if there's high content of cholesterol in bile and there's decreased motility, this is what will lead to gallstones. Gallstone will not happen all the time. It just precipitates. So if bile is just sitting there, it will solidify. Yeah.
So is it like protective against gallstones to eat like some fattening food?
Fattening food?
Like fatty food? Or
No.
a little bit of fatty food?
No. The more fatty food you have, the more likely you will also decrease it from plasma. And who is the main organ to remove cholesterol and fat from plasma? Liver. Liver. Now, when you have permanent stores like adipose tissue, you have a permanent stores. So liver has to work harder. How much can the liver remove? Not a lot. At the end of the day, it will keep storing it as well. Remember that. So, what will help see gallbladder contraction is organized. It can synchronize to your lifestyle. It can synchronize to your lifestyle. Do you guys need anything, guys? Rabbi, can you check if they need something? Maybe they need the whiteboard, I think. So, gallbladder, remember, gallbladder contraction can be synchronized to your life habits, to your diets. If you're eating frequently small meals, don't you think the gallbladder will contract more frequently? Yeah, take it. Somebody help her. Thank you. Thank you. Just unplug it first. Rabia? Very good. Okay. All right. So at the end of the day, obesity, fertility, female. Okay, these are risk factors for gallstones. 40s. Okay, so female in their 40s, and those who are obese, and those who are fertile, meaning having many children or many abortion or many pregnancies, are at risk. Okay, because estrogen promotes cholesterol uptake by the liver, which is a good thing. But if they have too much cholesterol in plasma, then it can lead to gallstones. You see, if a female has normal cholesterol, normal lipid and normal body fat content, then estrogen will uptake. It will actually decrease the risk of atherosclerosis. But when she has too much cholesterol floating around freely, a lot of it, then of course when you take up a lot by liver, a lot of it will be released into bile as well. Okay, so it doesn't have to be, look, I'm telling you, if a female is taking care of herself and she doesn't have a lot of cholesterol floating around in blood, then yes, estrogen will increase uptake, no big deal. Still, the quantity is not enough to cause saturation or precipitation of stones. Asra.
You said stasis leads to gallstone as well. Stasis of the gallbladder.
The risk factor. Look, gallstone is simply because of hypersaturation of what? Cholesterol. Now you can have it two ways. If your gallbladder is not contracting, and if we're not doing activities, and bile is just sitting there in gallbladder for a week, I mean, I'm exaggerating, you know?
Yeah.
Sitting there, of course you're going to precipitate stones. So that's immotility or stasis.
But what if somebody that eats like a completely low fat diet or fat lacking diet, could that be a risk as well because you're not causing the contraction of the gallbladder?
Yeah, stasis. Again, stasis can be in different ways. For example, you can have spasm of your bile ducts. That means, again, immotility. You can have tumor obstructing. You can have a stone already obstructing, inflammation, many things. As long as bile is not flowing, whether you eat or not, you're at risk. Yeah? I mean, not general eating. Lipids, fat diet. Yeah. Okay. Now, bilirubin stones. Where does bilirubin come from? Blood. Which part of the blood? The top or the bottom or the middle?
Oh, the breakdown of
Heme breakdown. So hemolysis. The risk factor for bilirubin stones is what?
so hemolytic.
Hemolysis. Very good. Hemolytic anemias. Hemolytic anemias. Hemolytic anemias. Hemolytic anemias. Now, let me give you a name of some hemolytic anemias. Hereditary spherocytosis. Hereditary spherocytosis. That's one. Glucose 6-phosphadehydrogenase deficiency anemia. Autoimmune hemolytic anemia. Anyways, just in general, say hemolytic anemia. The most important one I give you is spherocytosis, the most important one. Okay.
Sickle cell?
Sickle cell can do it too, yeah. All right. Okay. So chronic anemias, not acute anemias, right? It has to be chronic hemolytic anemia. Okay, very good. Now, for the final exam, be aware. If I give you a question of gallstones, either the person is a female in their 40s and obese and what? Fertile. Multiple children. Multiple pregnancy. Doesn't have to be children. Can be pregnancies, right? Could be spontaneous abortion. As long as she got pregnant multiple, it's an indication, it's a clue. If I give you a male with a history of hemolytic anemia, then you know it's bilirubin stones. Good? Are we good so far? Okay. Second thing. Cholesterol stones are non-pigmented stones. Bilirubin stones are pigmented stones. Cholesterol stones, non-pigmented stones. Bilirubin stones are pigmented stones. Bilirubin, as long as there's bilirubin, you can actually see it on CT, X-ray. Cholesterol stone cannot be seen on X-ray and CT. You need ultrasound for that. Okay, there you go. Are we good so far?
Can't they see both with ultrasound?
Yeah, ultrasound you can see both.
So why would you want to differentiate between them in terms of management?
No, CT scan is more accurate. It's much better. Ultrasound is not so sensitive at times. Yeah. Although the test of choice, the first test will be always ultrasound. Okay. But you might want to do sometimes CT scan to see if it's not tumor. So for a lot of different reasons. Okay. Now, risk factor for gallstone is, I told you, obesity, female, fertile, 40s for cholesterol stones, bilirubin, anemia, hemolytic anemias. Are we good? Okay. Risk factor for cholecystitis, gallstones. For cholangitis, gallstones. So, complication of gallstone is what? There you go. Cholecystitis and cholangitis. They are complication of what? Gallstones. They are complication of gallstones. Very good. Very good. Very good. Very good. Okay. All right. Now, so gallstones, the most common location where gallstones can form is neck of gallbladder.
Why the neck?
Because I think it's due to gravity. Okay, the neck, so it loops around it. It loops like this. So most stones will precipitate here. And also when the contraction occurs, this area is narrow, and then most larger stones, bile will precipitate here. Okay, yeah. Okay, so anyhow, neck and then body or fundus, and then bile duct. These are the most common location. But now, if there are gallstones can be asymptomatic. Look, we know the underlying cause, we know the risk factors. The next thing we want to know is, what's a big deal if somebody has gallstones? Most of them, they're asymptomatic. If they are symptomatic, what would they cause?
Acute pancreatitis or pain.
Complication, let's stay away from complication. Each complication is a disease by itself. So pain, recurrent pain, recurrent pain, recurrent pain. Okay, recurrent pain. And this pain will be where? Where's the location of this pain? Right upper quadrant. And this pain comes and goes, episodic pain. When will this pain increase?
With me,
With fatty food. Okay. Okay, when there's need for contraction of a gallbladder. Okay, so the pain will increase. Okay, and then this is nothing more than just about that. So, and then it leads to irritation of the gallbladder, and gallbladder can become sensitive and get inflamed. So those will be the complication. The complication are these two, so I'm not going to even write it. So that's pretty much it when it comes to gallstones. They're almost always they're asymptomatic. If they become symptomatic, it's cholecystitis, cholangitis. Okay. So now pain. Is there fever? No fever. Is there jaundice? No jaundice. So there's only one thing, and what's that? Pain. Okay, let me erase this part because you already know gallstone will always cause right upper quadrant pain, and this pain increases with fatty food or with meals in general, especially fatty food. That's a huge clue. Now, when it comes to cholecystitis is inflammation, right? Of gallbladder. Would you have pain? It's always symptomatic pain. Severe pain. Not colicky pain. I mean, not mild pain. It's colicky, severe pain. Worse than gallstones. Because gallbladder is now inflamed. Now, I think it was, what, today's Monday? Friday, somebody said Murphy's sign. What is Murphy's sign? Yeah. When you just have gallstones, there should be no Murphy's sign. But when gallbladder is inflamed and tender and swollen, and when you breathe in, when you inhale, gallbladder is compressed and it will cause severe pain. So on deep inspiration, you will have pain. Pain will increase. Now pain of cholecystitis, of course it increases what? Fatty food. But also it increases what? Deep palpation and especially deep inspiration. Okay, gallstone pain is not tenderness. But with cholecystitis, the gallbladder is inflamed. So you will have pain, which will increase with deep inspiration, with deep palpation in the right upper quadrant. Now, would you have fever? Yeah, it's inflammation, so there is fever. Would you have jaundice? No. Cholecystitis does not give you. Isolated cholecystitis does not give you jaundice. Jaundice is only when you have bile flow obstruction. When you have bile flow obstruction, I'll show you soon. Now, the most common cause of cholecystitis in terms of infection is which bacteria? Gram-negative bacteria is correct, congratulations, but give me the name of that gram-negative. E. coli is most important. Perfecto. Good. Good job. The number one cause of cholecystitis in terms of infection is what? E. coli.
Is bile sterile?
So how does E. coli come to gallbladder?
Does it go up the duct?
Yes, then it's called ascending cholecystitis. Ascending. Because E. coli will come from where? From the duodenum intestine and then go into the ampullator and all the way where? Now, what kind of bacteria usually would be able to cause? How many of you have done micro? I just want to see hands. Okay. Have you heard of Streptococcus family?
Yeah.
Tell me something about it. They're beta hemolytic, alpha hemolytic, or non-hemolytic? Anything else? Okay. They're in doubles or in chains. Anything else? I didn't take it.
Anything related to this?
Are they bile sensitive or resistant? Isn't that a test? There's a test. Streptococcus pneumonia versus viridans, use the bile test. Now, the only bacteria that should be able to cause cholecystitis, which ones? The one that are resistant to what? Bile. Bile, yes. And that's your homework. 4 pathogens for Wednesday. 4 pathogens. The one that are bile resistant, only they can cause cholecystitis most commonly. If they're bile sensitive, they'll be killed by bile. Okay. All right. Not all colon bacteria are bile resistant, especially not with a high concentration of bile. That is the homework. Bile resistant bacteria. Okay. If there's a fungus, if there's a parasite, if there's a bacteria, viruses don't have to worry about. Anyways, I need to know the names. Okay. I'm not going to test you on Wednesday. I'm going to test you on the final exam, so make sure you know it. Okay. And I'll only give you answer if you have done your job. So on Wednesday, if you ask me the name of those bacteria, I'll tell you only if you tell me what you have done. Alright. Pain, fever, no. Jaundice. But E. coli was one of the most common cause that caused ascending. Ascending means it goes all the way from intestine against the bile flow. That's why it's called ascending, right? Okay. Now when it comes to cholangitis, would you have pain? Of course. Would you have fever? It's inflammation. Would you have jaundice? Yes or no? Both. But for most cases, let's say yes. And you see, it's amazing how we differentiate based on symptoms. Only pain, recurrent colicky pain, comes and goes. Just some irritation in the right upper quadrant. You're going to think what? Gallstones. Gallstones. Then when you combine pain with fever, cholecystitis, especially if this pain is on deep inspiration. Cholangitis pain is not increased by deep inspiration. It's only cholecystitis. Okay. Suddenly when you have fever and jaundice, if there's jaundice, I'm telling you, if there's jaundice, this is 100% cholangitis. 100%. Lack of jaundice does not rule out cholangitis, but if it's there, it's 100% cholangitis. And I'll show you now why that is. So we have gallbladder, and we have 3 ducts, 4 ducts in this case. The only time you should have jaundice if there's bile flow obstruction. If bile cannot flow. Now bile is made where? In the liver. Where is it stored? So now I'll tell you this. A, B, C. C doesn't like me. D and E. Obstruction of which of the following ducts will cause bile flow obstruction? E is correct. Anything else? C is correct. Not D, no. Where's bile produced? In liver. This is hepatic duct. And this is hepatic duct. So bile keep flowing. Not a problem. If there's no obstruction here, it'll keep flowing. This means just the stored bile you cannot. Yeah. That's not obstruction to bile flow. Now jaundice occurs when bile obstruction is there. That means bile is not being secreted to the duodenum. It piles up where? In blood. When biles keep piling up and accumulating where? In blood. The only time it will start piling in blood if you cannot secrete it completely out of the liver or into the duodenum. Position D will not do anything. It just means you cannot store it there. That's all. But it'll still keep flowing.
But A and B don't cause obstruction.
If it's just A, no problem. If it's A and B together, yes.
Because of the XC.
Yeah. Okay. If it's just A, maybe mild. Okay, so you see, as soon as we have cholangitis, that means inflammation, swelling of these vessels will cause stenosis and obstruction. And that's the only time you will have jaundice. See, jaundice means bilirubin has to accumulate where? In your skin. In your skin. The only time it will accumulate in skin if it's accumulated in blood, and blood takes it to skin. Otherwise, no. Does it make sense? Bilirubin has to back up in blood and increase. Eventually, in the skin it backs up, and when the light hits it, it gives you a yellow color. Yeah.
So how can you have cholangitis without jaundice?
Okay, if it's cystic duct inflammation, if it's right hepatic duct inflammation,
Oh, if it's only one.
Yeah.
There's no complete obstruction.
yeah. So that's not bile flow obstruction, but still it's cholangitis, right? What does Ang mean? Angie. Vessel. Chol. What does chol mean? Cholesterol. So cholangio or cholangitis means inflammation of bile carrying, cholesterol carrying vessels, not blood. This is not blood vessels. Remember we said there's 3 types of vessels: veins, arteries, lymph, and bile ducts. Yeah. So bile carrying ducts are known as cholangio or cholesterol vessels, cholesterol carrying vessels. And then you have lymph carrying vessels. Lymphangitis, for example, you will say. Arteritis, vasculitis, or phlebitis, right? So, alright.
So, Moneer, if a stone comes out from the gallbladder and stuck in the duct,
Yeah.
would it cause jaundice?
Yeah. Which duct?
Common bile duct.
Yeah, of course. Yeah, it will.
What do you call it?
Same thing, cholangitis.
The same.
Yeah. See, the cholangitis, cholecystitis, gallstones, they're not different things. Stones are formed primarily where? In gallbladder. In gallbladder. They're formed in gallbladder. And gallbladder is big vesicle, right? But stones are relatively small, so they can obstruct where? The ducts. So now the gallstones, so when we have a stone here, if you just have stones here, let me just use this. There you go. Look, we have stones here. What would you call this?
Gallbladder stone.
Just gallstones. And if it leads to inflammation, gallbladder swells, and I'll use a little bit of this. Let's say gallbladder swole. It's swollen a little bit. Now what do you call it?
Cholecystitis.
It's the same thing. It's just a complication of it, right? Now the same gallstones gets dislodged, and it comes and obstructs here. What do you call it now? Cholangitis without jaundice. And if the stone comes here and obstructs here, what do you call it? Cholangitis, but obstructive cholangitis. Obstructive cholangitis. In D, non-obstructive cholangitis. It is obstructive only to gallbladder, but not to bile flow. Okay? So D will not give you jaundice, E will give you jaundice. If gallstone is here, same thing. It's obstructive cholangitis. Okay?
So how does a gallstone form from the liver? The liver only makes like very small amount of protein.
How does it form in the liver?
Like how, yeah, how does it form like from the common hepatic duct basically?
Yeah, so if you have some sort of flow problems, liver give you sinusites. And then tiny stones, and they come and they go further and further and divide, and then gets to this place, and the small stones will precipitate. Okay? But that's why liver, hepatic, gallstones are rare, extremely rare. Most stones are where? Gallbladder, because it's a storage place. There's not much contraction, there's not movement.
So the most common like jaundice, cholangitis is going to be obstruction at E.
Yeah. Yeah. Okay. Are we good? Now, so gallstone is a major risk factor for what? Cholangitis. Anything else?
Acute
Fistula.
Pancreatic, head, cancer or mass, yeah? Okay, that means obstruction where? Now it's pancreatic mass that causes obstruction of ampulla vader right here. Yeah.
Which one is like ascending cholangitis?
Ascending cholangitis, both, look, cholecystitis and cholangitis are both known as ascending cholangitis and ascending cholecystitis if bacteria is involved.
In which one?
In both.
In both?
Yeah. Ascending simply means bacteria went backward from intestine into the gallbladder or bile duct. Okay? If it's just irritation, non-inflammatory inflammation, then it's not ascending. The term ascending we use only if bacteria is involved. Make sense? Yeah. Yeah.
So what keeps bacteria from going up the bile ducts?
Bile flow. You see, can you swim against a fast flowing current of water? A waterfall? Something like, no. That's why bacteria cannot go into gallbladder normally. Or bacteria cannot go into kidneys normally, urine flow. When flow is obstructed and blood, in this case urine or bile is slow, then bacteria can swim, especially those who have flagella. E. coli has that. Okay. So you'll be looking for organism that has flagella and at the same time are resistant to what? Bile. Okay. Second thing, I just remember something I forgot. Oh, one more thing that can lead to cholangitis is sphincter of Oddi. Sphincter of Oddi, malformation or defect. Meaning the sphincter of Oddi is primarily closed, most of the time closed. It doesn't open properly. What happens to bile flow? Obstructed. If the sphincter is closed 24/7, rarely open, that means more bile is accumulating. And that will give you again the same pain and same issues. Okay. Alright, so good. So I hope you can differentiate them based on what? These three symptoms. Gallstone 1, cholecystitis 2, cholangitis 3 symptoms. Remember, to diagnose these three or differentiate between them, you don't necessarily need to do an examination. On clinical signs, you can actually identify it or differentiate it. What would you do in terms of tests?
Ultrasound.
Abdominal, ultrasound, and you will see stones. Okay. What else would you do?
CT.
CT. If abdominal ultrasound is positive, you don't need to do CT. Okay.
Blood test.
What would you find on blood test?
Increased calcium.
Excellent. So you can now, if somebody has jaundice, you don't necessarily have to do that. But let's say you do blood test, blood bilirubin, right? You will look for blood bilirubin, right? Now, there's two types of bilirubin: direct and indirect, conjugated and unconjugated. Direct and conjugated means the same thing. Indirect and unconjugated means the same thing. Unconjugated, conjugation is the function of liver. Conjugation is the function of who? Liver. So if you have, now the only time you look for bilirubin, bilirubin will tell you like if it's hemolytic anemias, right? So if it's unconjugated bilirubinemia, it just tells you anemia that is mostly intravascular. Intravascular anemia. Okay, so bilirubin, intravascular. But usually, if you have unconjugated bilirubinemia in terms of hereditary, it wouldn't cause gallstones. It wouldn't cause it. Because the liver is functional. Bile flow is functional. Huh? What about it? To be increased? If there's obstruction, otherwise no. Yeah. Otherwise no.
You're looking for high conjugated bilirubin?
No, it just tells you something else. We have to study liver overall, then you will know. Okay. So just look for bilirubin. Now you have unconjugated bilirubin or conjugated bilirubin. If they're increased, just simply tells there is bilirubin. That's all, nothing more. So that test will not help us necessarily. It would only help us. The cause of this stone is what? Bilirubin. Yeah. But you can do, if ultrasound shows you positive for stones, and then you do bilirubin, CT scan and shows you stone, then you think it's pigmented stones. Yeah. So, but there's something else known as endoscopic, retrograde, cholangioppancreatography. Endoscopic, you put a scope through your oral cavity, go through esophagus, go to the duodenum, and it goes back where? Through bile duct. So that's why endoscopic. Retrograde means backward. You're going against the flow of bile, right? That's backward. But it could be used for both pancreatic duct and bile duct. So that's why it's known as cholangioppancreatography. You can visualize the ducts of pancreas or bile ducts. This procedure. Now the procedure is used to visualize if there's a stone and remove it at the same time. It's therapeutic and diagnostic. Okay, it's therapeutic and diagnostic.
So in this case, it would be before blood delivery?
Yeah, it doesn't necessarily mean. Yeah. If the stones are too large, sometimes you can't do anything, you might have to do that, but you can use medication and other things to dissolve stones if you could, right? Okay. So you will use these tests. Again, if it's recurrent gallstones and there's no solution, what would you do in terms of management?
If it's gallstone,
Yeah.
remove.
Remove gallbladder. Laparoscopically remove the gallbladder. No big deal. Okay. And again, the question earlier here was, some of you were not here, that if somebody has no gallbladder, what would happen? The eating habit will be changed, your bowel movement will be changed for a while until you get adjusted. So the first few months, weeks, depending on your physiology, you might not tolerate fatty food so well. Okay, it will give you bloating and diarrhea and stuff like that. But then eventually you get adjusted. Alright? So now, cholecystitis and cholangitis could put you at risk of cancer. It could put you at risk of cancer. So therefore, you know, in those cases you have to be aware of that.
So the inflammation causes high turnover.
Huh?
Because the inflammation causes high turnover.
Yeah. Alright. Okay, let's take a break.
I was watching as you left them all over.
Walaikum salam, how are you? That's okay, that's okay. I know when you call it's probably important, so that's why. I just took a break. Yeah. Yeah, yesterday I heard that there were Luqman and Omar had some conflict, so I mean your younger son Motaz, yeah. Okay. 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 Okay, yeah. No, just today, that's fine, inshallah. Bring them. That's good. Yeah. Instigating it, yeah. that's not good. Yeah.
That's not the word that comes to me. Back to Harvard. But, I know, I wanted to, my brother was going to record on this, but they were fine. They recorded themselves.
I don't know what she's saying with the drums.
Yeah, that's not good. I mean, that's very immature. So, and your family friends too. So that's
How many people go before you? Well, that's true. She's saying
no, that's good. Just bring them. Yeah, bring them. Yeah. Yeah, please do that because you're both families, and they should respect each other. Like even if they didn't know, they shouldn't go to that point. But they're kids.
He was before me, so I was like, unfortunately, I was so scared. I got next.
your brothers were consoling you or not?
Yeah.
Yeah, right.
My brothers?
Yeah, it's okay. It's okay, fair, inshallah. Just bring them. That's fine. Okay. Yeah. Salam alaikum. No, it's okay.
It's nothing. It's nothing. It's fine. Nothing. Once I know, talking. Once I get involved, then it gets easy.
How long was your husband?
They had cases they actually sued, patients, so that's what a lot of they next one
I need support. One thing I noticed why you guys have been
well, with me, I had to get this at times.
but you don't game much.
I know. Oh, yeah. My kids are always playing basketball.
Yeah, I started with
Getting in and out. Really good, huh?
Assalamualaikum, Dr. Moneer.
How are you?
MashaAllah, well.
Good, good.
I want to ask you, on gallstones, if you do urine test, huh?
Yeah.
So, don't take it, please.
Take a half. Take a half.
Just break some, please.
Just take it. You're trying to be.
If you do urine test, what would show up? Like the amylase or anything like that, or nothing? Why not?
Plasma test. That's good. Okay, so let me
Would
erase
those
this.
stones also cause, could cause potentially obstruction in urine?
No, 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 no. That's good, but you will have increased alkaline phosphatase.
Amylase?
No,
Amylase?
but let me write it here. That's good. So you're talking about some important stuff. Amylase and lipase. Good. Good questions. You should have asked me them.
Oh, I wasn't sure. What about
No, 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 just ask me. Don't worry about people.
How did your thing go on Saturday? Your questions? Did you guys meet? Sorry, I didn't know I had to go to Marcel.
Tomorrow.
Oh, you do? What time? After class? After...
1. Yeah. Because it's curved and whatnot. But I got number 17 right and I got him marked wrong on here, even though I got a 25. Okay. But I understand. I added 4 points regardless.
Is that good? Because I know you say for a scholarship, it's only raw score.
Okay, for scholarship, as I said, look.
But I want my raw score because I'm doing good.
Yeah, for
I should
scholarship.
have 9. Like this one is right there. Let's see. I didn't check the rest, but I remember
I
this.
didn't even, as I said, I counted this raw score. I mean the whole
whole
125, yeah. The next exam will be
Is it ones that are next? Do we have another exam before the final?
this Monday coming up.
I just missed Colin, right, on Friday?
How was
That's
the
old.
conference? Yeah. Took pictures, videos, what?
Took pictures, and I took videos of the questioning. They wouldn't let them record the actual full presentation.
No, you were.
Yeah, I got little clips of video, like when they're questioning at the end. And they let us actually present on stage.
Really?
Yeah,
That's good.
yeah, so I presented my presentation, then I just took questioning afterwards on the side.
That's good.
Yeah, so it was really good. I was scared at first.
It was to you or her? It's a text form.
Huh?
I don't know how to fill it out, so.
What is it?
I want to do
Text form.
Oh, tax.
this type of thing that I'm supposed to
Okay, so
listen
you
to.
have to, everybody's asking about this. Let me tell you something. This is
That's what his accountant gave me.
1098. Now there's the issue. Because our school is international school, because we do taxes there. Now, I don't know how IRS will take this. You need to talk to your accountant. Is there a separate form for international entities?
Okay.
Because if you fill this in and 5 years later they come and they say, you know what, the school was there, you did the wrong form, you might get in trouble.
They're
So
gonna
let him
ask
know
you,
to
they're
give an
gonna.
international form?
Yeah, I'm sure, because Canadians have international forms.
Okay.
So I don't know about the US.
They'll send you a thing to, like, you owe them money at the end of the day. They'll come
Yeah.
after you for money.
Okay. So that's for international?
Huh? Oh.
Okay.
Okay, guys.
Question about the exam. But let me just double check.
Okay. So, let's say somebody comes with complaints of, cholecystitis or cholangitis. Let's say somebody just complains, oh, they have right upper quadrant pain and they have fever. Jaundice, not necessarily, no jaundice. And then you see there is increased bilirubin in blood. It indicates that there is hemolytic anemia or obstruction of bile flow. Okay? Look, if bilirubin is increased in blood, you will have to assume this is cholangitis. Why is there bilirubin obstruction? Why is bilirubin accumulating in blood? There has to be some sort of obstruction. Or your liver is, or there's a problem in the liver, it cannot conjugate it. So it depends. If it's conjugated bilirubinemia, that means obstruction. If it's unconjugated bilirubinemia, it means what? Hemolytic anemia. Or the liver is not able to conjugate. A problem is in the liver. Again, that's liver disease, so we'll come to that. Next thing, if you have same symptoms, but you have ALP stands for alkaline phosphatase. Alkaline phosphatase. Alkaline phosphatase. Alkaline phosphatase is primarily produced by bile ducts. Alkaline phosphatase is produced by who? Bile ducts, bile ducts, bile ducts. So if you have increased plasma alkaline phosphatase, it indicates what? Cholangitis, 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 or some sort of irritation or cellular damage of bile ducts. Because it's within the cells. When the cells rupture, they will release a lot of alkaline phosphatase. So that's for this. But on the other hand, what if you have something else, completely something different? And that is you have increase in amylase and lipase. That means it is pancreatic cancer or pancreatitis is the cause of it. Okay? So in this case, you will think of pancreatitis or pancreatic cancer, the cause of bile flow obstruction. Alright? So you have to know these, how to differentiate between them. Okay, cholecystitis can lead to chronic cholecystitis. And that can lead to porcelain gallbladder. And that can lead to gallbladder cancer. So complication of cholecystitis.
Porcelain gallbladder?
Yeah, this can become chronic cholecystitis. Or can become porcelain gallbladder. That means, this simply means, I don't know if you guys know what's porcelain. It's sort of thing that you use in kitchens and stuff like that. Huh?
A lot of countries.
In dentistry as well. Okay, so on X-ray or CT scan, it will glow bright red. I mean white. Just like calcification. So this leads to calcification. So on X-ray and CT scan, you will see gallbladder. The rim of gallbladder. Let me just see if I can do this. Gallbladder. Let's say this is gallbladder. Now, around the edges of gallbladder, you will see some calcification like this. Okay, this is porcelain gallbladder. So it's chronic irritated gallbladder, chronic cholecystitis, accompanied by calcification. Calcification. So actually porcelain gallbladder means gallbladder calcification. Gallbladder calcification. What's the big deal? It is at risk of gallbladder cancer. Huge risk. Okay, so that's the two scenarios you need to understand. Porcelain gallbladder simply means calcified gallbladder. Calcified gallbladder. On CT scan or abdominal X-ray, you will see that the rim of gallbladder is bright white, not dark. Because gallbladder mostly full of air, so it will look dark on CT scan. But in this case, the rim of it, the edges will be bright white, as if it's calcified. And that tells you what? If you ask, what is this patient at risk of? What is the big deal? What do you have to do? They are at risk of gallbladder cancer. Okay? Okay. So we're done with gallbladder. Let's move on to liver. Liver. Okay, I'm trying to change the blue. It's not going to change. Good. Alright, so liver. Now, first thing is with liver, guys, what's the anatomy of the liver?
It has 4 lobes,
Okay,
right, left, and there's caudate
Cephalic or diaphragmatic? Same thing. Okay. First thing is liver. The entire right side of your abdomen is occupied by liver. The entire right side of the abdomen is occupied by who? Liver, liver, liver. And it's related to ribs what? 7, 8, 9, 10. Okay? Alright. On the right side. Okay. In the hepatocytes of liver, so in terms of anatomy, that's all there is to it. Honestly, just remember, what are the structure related to the liver now? Superior to the liver, what do you find? Diaphragm. Right of the liver, what do you find? Ribs. Left of the liver, what do you find? Stomach. Esophagus. Duodenum. Inferior to it, what do you find? Duodenum, transverse colon. Which transverse colon?
Ascending and first.
The right half. The right half of transverse colon. And what else? Gallbladder. What else? Portal vein. What else? Okay. Vena cava. Okay. And of course, kidney. Which kidney? Right kidney. So you got to know those, the gross anatomy of liver. Where it's located, what are the structure related to it. Is that okay? Again, for anatomy, try not to read. What are you going to do? Look at pictures. Look at pictures. Become photographer. You have to become photographer. Okay? And analyze. Look, photographers, when they look at pictures, they don't just look. They see the relationship of the sizes and this and this and that, right? So that's what you have to do with anatomy. Okay. How about circulation of liver?
Common hepatic artery.
Okay, so now let's start with blood supply. Let's start with arteries first.
Common hepatic artery.
So celiac trunk gives you what? 3 branches, right?
Left gastric.
Left gastric,
Splenic.
splenic,
Common hepatic.
common hepatic. A common hepatic will give you the duodenum, right? Gastroduodenal, and then it will give you hepatic proper. Hepatic proper will give you then, and then it will give you a cystic duct to the gallbladder. So there you go. Good. So that's one. Now this blood actually brings oxygen to hepatocytes. Oxygen and some nutrients, right? So that's one. How about other blood supply?
Portal vein.
Okay. And you know what? I should have done this. Let me just do this. So this hepatic artery, we'll just call it this like this. And then you have portal vein. Very good. Portal vein will make it a little bit blue. Portal vein. Portal vein, and it's made of what? Splenic, inferior, mesenteric. And then this will go along here as well. And of course, you know, the bile duct will go like this. Okay, so the relationship of these three are very important. Remember when you talk about the lesser omentum having free margin, and then the portal triad there? Yeah, very good. So the portal triad is what? Bile duct, hepatic artery, portal vein. Good. So since we're talking blood supply only, let's focus on that blood supply. Now two vessels. One is the hepatic artery, which brings blood into the liver, and one is portal vein, which brings blood into the liver. Now portal vein brings blood that is rich in nutrients from GI, or all the stuff that's absorbed from GI, especially carbs and amino acids. Okay, so amino acids and monosaccharides, they're brought from where? From intestine into the liver. But guess what? Something else bypasses this. Lipids are not brought by this vein. They go to lymphatics. Good. So there you go. And then the portal vein, so the arteries, maybe I should make this a little bit darker, the liver, so we can see. Of course, this artery, the hepatic artery, will split into give you many branches, right? And it will spread all over to supply all lobes, all cells of the liver. And portal vein, similarly, portal vein will also split all over. It'll go along these arteries, follow them. But there's a vein, or two of them, or one of them, that drains the liver. Hepatic vein. But this vein started somewhere. This vein will start from the liver. And all these will combine together to make the hepatic vein. And the hepatic vein will drain into inferior vena cava. Inferior vena cava. And let's say inferior vena cava is going somewhere here. Okay, just to show you, that means you see the posterior surface of left lobe of the liver has impression of vena cava because it's pressing against the vena cava. Okay?
And the aorta.
And aorta, yeah.
The aorta is on the other side.
Huh?
Isn't the aorta on the left side?
Yeah, but it goes all the way. The liver goes beyond the esophagus. The tip of it, yeah. Alright, so I hope this makes sense to you. Blood supply of liver is 3 vessels: hepatic vein, portal vein, hepatic artery. Okay? Alright. Hepatic vein carries blood away from the liver. What kind of blood? Deoxygenated blood. Portal vein and hepatic artery brings oxygenated blood into the liver. Okay? Alright. Okay, next thing, let's go over histology of liver. See, the functional unit of liver is known as lobule. The functional unit of liver is known as what? Lobule. Okay. In the center of lobule, the lobule usually, the lobule is hexagon shaped. The lobule is a hexagon shape. In the center of it, you have hepatic vein. In the center of it, you have hepatic vein. Let's say a lobule is this shape, just to see it in 3D shape. So, okay, just to we can visualize it. Now, a lobule is made of many hepatocytes. Many hepatocytes. Look, this hexagon shape is not a shape of hepatocytes. So this will be one hepatocyte. Technically, the shape of hepatocyte will be this shape. If I were to do this, is one hepatocyte. Okay? This is a hepatocyte. A square cell. So that means a lobule is made of many hepatocytes, or edges of hepatocytes are there, about 6 of them. Okay, it's a functional unit. Now in the corner of each lobule, in each corner you will have hepatic artery. Hepatic artery, and let's say this way, it's going down. Hepatic artery. And you will also have bile duct. And you will also have portal vein. So the portal triad, if you think about the lobule, it has portal triad around it. In the center of it, it has what? Hepatic vein. This is a lobule, which is the functional unit of liver. That means liver is made of repeated unit of these. If you understand one single lobule, you understood the whole liver.
What the lymph?
Huh? Not much. Lymphatic is different. It's more superficial. Okay? Lymphatic will not follow this architecture. Lymph will go along the veins mostly. The central vein. Okay. Now, if this is the hepatocytes, right? So let me show you the hepatocytes. So this is a single hepatocyte. This yellow. This is the hepatocyte. Bile duct will start as a blind pouch. Here it would be much easier. Bile duct start as blind sacs. Blind sacs, and they will empty to where? Into this. Okay, so what do we call small ducts? Have you heard of canaliculi before? Okay, so this dark green is bile duct, small bile ductule. And then the bright green, right here, this one, is bile canaliculi. Okay, each one of them will empty. So there's at each level they empty into what? So there's one coming from this side, one from this level, one from this level. Multiple of them empty into what? Bile ducts, tiny bile ducts, not the major bile duct. Okay, bile duct, they're all called bile ducts, but you have smaller and smaller and smaller and smaller. And then the smallest one is known as ductule. Ductule. Okay. So this canaliculi will drain into what? Bile ductule. But guess what? It is these bile duct that produces bile. So hepatocytes will make. Now we have to know what is bile made of, first of all. Okay. Let me accompany this by liver, by blood. So this hepatic artery will give you a tiny branch. This branch will go along this duct. Hepatic artery brings what? Oxygenated blood, right? So as it goes closer to the hepatic vein, what happens to it? The color will slowly change because it's carrying deoxygenated blood eventually. That means the capillary, there will be a capillary, right? So around the ductule, around the sinusites, so bile canaliculi, this green area, what can I label this? This area, look what I labeled 1. This is known as bile canaliculi. Bile canaliculi. Canaliculi means many. Canaliculus 1. Or you can call it bile sinus. So this is along these blood vessels, these capillaries. So oxygenated blood comes and it will take back deoxygenated blood, will go into the hepatic vein and drain. So you will have the same thing all over the place. Let's say here, and then here, and then here, and then here. But the bile ducts are blind pouches. Remember, they will simply carry bile. And oxygenated blood will come and become deoxygenated, and deoxygenated blood is carried by. So blood flow, if I were to show you blood flow, here's the arrow of blood flow. Yeah, and then goes here, and then hepatic vein carries it. And when it comes to bile flow is in this way. Yeah. And all these ducts will combine to make what? Eventually one right hepatic and one left hepatic, and then hepatic duct. Get the idea? Yeah.
The oxygenated blood is feeding the bile canaliculi, and that's why
No, it's feeding the hepatocytes
the hepatocytes and that's
and the canaliculi.
then it becomes deoxygenated.
Yeah. Okay, it brings oxygenated blood, and then the tissue will extract oxygen and give them carbon dioxide. Okay, now, so hepatocyte in yellow, what do hepatocytes do? We have to discuss the function of hepatocyte. At least one function of the hepatocyte is to make bile. One function of hepatocyte is to form bile. Bile. What is bile made of? Cholesterol. Anything else?
Phosphorescence,
There you go. Cholesterol esters. Anything else? Bile salts. Bile salts and bile acids. Anything else? Bilirubin. What kind of bilirubin? Yeah, it should be conjugated. Bile duct should be only carrying conjugated bilirubin. After the liver conjugates it, then it will secrete into bile duct. Anything else? Huh? IgA. Anything else? Water and electrolytes. Okay. All right. Ooh, ooh. That's from the guy from Texas movies. All right. McConaughey, whatever his name is. Okay, are we good with this? Yes, sir. Alkaline phosphatase is produced by the bile ducts.
But it's not one of the components.
Not necessarily, no. It shouldn't be. The only time if you have bile duct injury, it will be released. Not normally. Yeah. Okay. hot tea?
Yes.
Nice. Thank you. Ooh, thank you. You guys are so nice.
You're spoiling our kids.
Yeah, I'm spoiled now. Big smile on my face.
Spoil us too.
Huh?
Something for us.
I'm spoiling you with knowledge.
No,
That's the
not
best
you.
spoiling.
Exactly.
Not bringing any keys and you don't, that's what they're bringing all the time.
Yeah. Well, if you study in a group with them and help them, they will do that for you.
Yeah.
Yeah. All right. Function of liver or hepatocytes. So one function of hepatocyte was what? Or liver overall? Let's talk about the function of liver. Detoxification. Detoxification. Okay, what does detoxification mean in this case? Okay, so he's saying is the system that does is P450? System of enzymes. Very good. This enzyme causes detoxification of what? Drugs. Anything else? Medications and drugs are the same thing, right? Metabolites. Okay. So food product, right? Anything else? Toxins, yes. Okay. Anything else? What are some toxins? Okay. Now, when we talk about infectious toxin, no. That's lymph node. That's lymph node. Okay. What are some drugs or medication? Acetaminophen. And statins. Very good. Benzos. Yeah. Which benzos?
I know all of them except I think lorazepam, desvectine, and then I forget.
Lot.
Temazepam.
There you go. Yeah. Okay. Benzos.
The rest are all
Okay. Okay. So drugs again. I shouldn't have, but whatever. I put medication there. So ethanol in those things, of course. It also stores things, right? So that's one function of the liver is to detoxification. It stores stuff. It's a storage. What does it store? Okay, glycogen or glucose or monosaccharides and lipids, right? Triglyceride. Good. No, estrogen is actually detoxified. Thank you for reminding me. Good job. Estrogen is detoxified by the liver. Okay. Now triglyceride, glycogen, anything else stored? Any vitamin? Good job. Vitamin A for Canadian A. Yeah. Okay, so that's two functions so far. Anything else for liver? Any other function? Bile production, bile synthesis, which automatically includes bile acids, right? So bile acids are produced where? In the liver by hepatocytes. Conjugated bilirubin? Okay. Anything else? And let's say cholesterol as well, because cholesterol is cleared. Protein synthesis, that's amazing. Whoever said that is congratulations. Congratulations, my friends. If you're my student, even better. If you're my friend, that's good too. Okay, so bile, no, you said protein synthesis, right? Protein synthesis. Protein are synthesized in the liver. Can you name some? What kind of protein anyways? Plasma protein would be much better. Let's say plasma protein. Plasma protein. Apoproteins. What are apoproteins for? They're known as what? Lipoprotein. Transport of lipids. Good job. Anything else? Compliments. Thank you for complimenting me. So nice of you guys. You like my hat? Okay. Anything else? Albumin, absolutely critical. And plasmin. Anything else? Clotting factors, congratulations, you received a bonus. All clotting factor except which one?
5. Guess.
Except? Huh?
7. I'm guessing.
8. 8. Okay. Anything else? Oh, I guess that's good. Okay. What's the function of the liver? Glycogen synthesis. Huh? Very nice. Gluconeogenesis. Okay. Very nice. And how about ketogenesis? Yeah. Anything else the liver does?
Lipogenesis and adipocytes.
I'm getting tired and bored. Anything else? Yeah. One very important thing. Liver, under circumstances of emergency or when needs to, can replace bone marrow's function. Can do erythropoiesis. Can make RBCs. Can clear them too. Can clear them and make them both. In fetuses, liver used to do it, but in adults it switches to bone marrow. So in fetus, first RBC production starts with yolk sac, and then moves on to liver, and then after birth, bone marrow. Alright. Now, what if somebody has liver failure? What would they be complaining of, or they'll be suffering from? All of this. Can you give me an example of liver failure? Cirrhosis. Liver cirrhosis. So we will discuss liver cirrhosis first. How long have we been doing this?
About 40 minutes.
Okay, let's take a break and we'll come back to this.